Topic of our joint lecture here today, our chat, is hopefully you can see it now. That not all pains are the same, and it's intended to be. I'm gotta get things up on my own screen. Here we go. It intended to be just a general discussion related to pain and pain mechanisms, because there is this perception sometimes that every single pain that someone has must be the same and therefore is treated the same and things like this. And the reality is both clinically and through a basic science standpoint, that's just not true. There are many different types of pains that are present, and those different pains have a physiologic basis to them. So we're going to have two parts to this overall lecture. I'm going to first just talk about clinical pain and what's kind of observed, that there are different types of pains and they are treated differently. And then Dr. DeBerry is going to be talking more specifically about the neurophysiology and anatomy of pain to, again, be able to see in what way they are different. So like in all lectures, you got to start off with some definitions. The definition I'm putting up here is sort of both the old and the new definition put forward by the International Association for the Study of Pain, which is that pain is an unpleasant sensory and emotional experience that's associated with actual or potential tissue damage. Normally the extension is put on is that, and it's also described in terms of that damage in the sense that it is things that are cutting, burning, rending, tearing. They're the descriptors that we use when our body is being attacked and destroyed. They're the sensations that are evoked by that. The bottom line, however, is that ongoing tissue damage does not have to be present for pain to be experienced. It can be a sequelae of previous pain, or it can be a state where normal sensations have been converted into a more hypersensitive set of sensations. There is always this question of, well, who treats pain? Because there are pain doctors, and I'm one of those kind of people. I used to work over in our pain clinic. I still do in-hospital pain management. And we see a group of patients periodically that are experiencing pain, but not certainly all of them. In fact, if you kind of look at the list, it's basically almost everyone in medicine deals with pain. In fact, somewhere between 60 to 80% of people who enter into the medical system are motivated to do so by pain in some way. Either they've broken a leg, sprained an ankle, they're in labor, these types of things. It's pain that motivates people to see these people in the medical system. And notably, as you can see from the list, it's not just doctors and nurses, it's also psychologists, physiotherapists, complementary and alternative medicine people. There are a lot of people out there who make their career, a significant part of it is trying to assess and appropriately treat pain. And we all realize, again, there's more than one type of pain. And so you have to tailor specific treatments to individuals as we go. So how do we classify pain? That is, how do we break it up into these different sorts of groups? And there's a variety of systems that have been derived in these sorts of things. There certainly are anatomic systems, that is, where is the pain coming from? And that's sort of the simplest, except it doesn't always tell us necessarily about what's causing those sorts of pains. What is it? What's the underlying mechanism? That's where we bump into etiologic, which is that's the root source of the pain generation, that either it's a aberrant nerve firing or it is active inflammation of a joint. That's the etiologic therapies. And ideally, we would always have a proper etiological therapy for everything we treat. But a lot of the time, all those specialists that you saw on the list, what they're doing is trying to figure out that etiology so that they can sort of move to what they think is the most appropriate medicine. There are also qualitative descriptive classifications. Some people will lump together burning pains versus lancinating pains, these sorts of things. That's actually not proven particularly helpful in a research or clinical standpoint, but it's very commonly utilized. But I would say actually from a clinical standpoint, the one that's used more than anything else is just sort of a lumping of things as a temporal characterization. That is, either a pain is fairly acute, as in it's just happened, or it's chronic, it's been around, and I'll give you some maybe better definitions than that. When we talk with acute pain, the bottom line is it itself is not the treatment problem. Most acute pains are short-acting disease process or specific event related. And even if we don't treat them very well at all, they'll get better. Therefore, they don't, in the medical system, they don't comprise these issues. Again, treatment of time is, tincture of time is just as good a medicine as almost anything else. And what you do is you do certain treatments in the meantime while you're kind of working with it. The real problem in clinical pain management is more chronic pain. And that has a fuzzy definition that's different depending upon what source you're looking at. The one I use is the one that a guy named John Bonica put forward, his fuzzy definition many years ago, which is just, it's a pain defined as something that lasts longer than it's supposed to. In fact, he put an extra month onto the lasts longer than planned. And that's because different disease processes should have a different duration of effect. You break your hip, that has a certain amount of time it's going to take to heal versus you just cut your finger. Both of them caused pain, but one of them should have a resolution of the pain a lot faster than the other. The thing about chronic pains too is that they're often without precisely defined etiologies. That is, we don't always know the precise mechanism that's leading to that pain. And we do have this issue of, unless we know the precise mechanism, how are you supposed to logically treat these disorders, particularly if they're not all the same? Well, I put up here a list of common diagnoses, and I put that in parentheses here, because what you look at is these are diagnoses that go down on patient charts for what's their source of pain, but realize most of these aren't really diagnoses, they're just descriptions. What are headaches, but it's you've got pain in your head. What is back pain? You got pain in your back. It's not telling you about a slipped disc, it's not telling you about migraine, it's not telling you about these other things, but these are the diagnoses that are most commonly utilized that are in there. Abdominal pain, pelvic pain, they're descriptive diagnoses. So the classification scheme that I'm going to talk a little bit about is the one that ends up sort of guiding therapy. That is, how do you make a decision about how to treat something if you don't know the precise reason that it's happening? And a treatment-related pain classification is the one that has at least these two components, the nociceptive pains and neuropathic pains, but there's always other pains that we're not completely sure what they are. The most recent IASP came out and came up with a term called neuroplastic, which is things that sort of have neuropathic qualities, but not quite all the same neuropathic qualities, and maybe no evidence of nerve injury for these things. So let me define these things for you, and then we'll also define about how it is that we go ahead and treat them. So the therapeutic pharmacologies that are for these two different types of pains, the nociceptive and neuropathic, are sort of night and day different. The nociceptive pains are those things that respond to traditional analgesics. That would be opioids, anti-inflammatories, and their associated medicines, versus the neuropathic pains are ones that respond optimally to adjuvant analgesics, and I'll have to define what that means, but it's basically not opioids, not anti-inflammatories, not the normal things that people think of as pain medicines, but that these adjuvant analgesics are often more effective than a bunch of narcotics in that sort of setting for that particular type of pain. So what's nociceptive pain? It's the pain that most of us have understood since we were children. It's the pain that they teach in med school. It's the pain of textbooks. That is where there is an actual or potential tissue damage of non-neural structures. That is, something is cut, burned, rended, poked, all these sorts of things. That is nociceptive pain that has a definable tissue damage associated with it. And it does have definable pathology, but notably in the clinical realm, symptoms may be out of proportion to the amount of pathology that's observed. That is, it can be a small little burn on the finger, but it's a 10,000 out of 10 pain that is being rated as. That is, symptoms may be out of proportion to the amount of tissue damage, but it's still a nociceptive pain as a course because it's related to tissue damage. Good examples of nociceptive pains are things like postoperative pain, procedures-associated pain, having dental work, trauma-associated pain, like this broken femur that you kind of see have a thing here. That picture still makes me cringe whenever I kind of look at it. And as well as tissue-destructive cancers, arthritis, and inflammatory visceral diseases. These things are all things that have ongoing tissue damage and the associated changes of tissue damage going with them. There are various signs and symptoms that go with this damage and inflammation. They include things like redness, swelling, pain, of course, that's what we're talking about, but also warmth. And what can happen about nociceptive pains is sometimes they can be hidden. That is, all of this signs and symptoms of damage and inflammation may be going on deep inside a joint, for example, like inside a hip joint. And you may not see redness, swelling, all these things, but you do see the pain that's associated with it. If you look in there, which is what they do with arthroscopy, for example, in the hip, then they do know they see the redness, swelling, and the other sorts of things. Now, the effects of pain are very reliable with nociceptive pain. There are things like increased adrenaline out of your system. You get an increase in heart rate, increase in blood pressure. It's both epinephrine, norepinephrine release. It's a sympathetic response. There's also an increased stress hormone response. There's also respiratory effects, autonomic effects like sweating. And a key thing is that there's psychological effects. That is, it causes aversion. You don't like it, and it causes distress in that sort of processes. Again, these are very reliable when people are experiencing a tissue damaging event. Well, that brings us to the other type of pain, which is this neuropathic pain, which can be due to injury of neural structures anywhere along what we define as the pain pathway. And the more we start learning, it's the more places that are part of the pain pathway. There are peripheral nerves, certainly. There's the spinal cord, the thalamus, the cortex, a lot of different other areas. And the bottom line is if nerve injury happens to those places, like a peripheral nerve being crushed, the spinal cord being injured, a secondary effect of that injury is commonly a pain that goes with it. The thing about these pains is they may be immediate when the nerve is being crushed, for example, or they may be delayed. I mean, that is a classic example is a nerve gets cut and people they're feeling numbness in an area, but 2 to 3 weeks later, all of a sudden it starts burning and having all sorts of other sensations in that area. These pains can often appear very bizarre because we're not actually seeing a lot of pathology sometimes present, but people are just having a significant amount of pain. And so by definition, it's out of proportion to the pathology because generally we don't see the nerve pathology that's leading to this particular type of pain. The effects of neuropathic pain are just basically unreliable in comparison with nociceptive pain. You may or may not have increased autonomic responses, adrenaline responses, respiratory responses. The only thing that is reliable when it comes to neuropathic pain is the psychological effects that it produces aversion, it produces distress, it just hurts even if there's not a good visible reason with redness, swelling, and all those other things to say why it hurts. What we do to try to diagnose and get if something as being a neuropathic pain is we look for evidence of nerve injury. We do things, of course, like physical exam, and you look for things like hyperalgesia and allodynia, and those are fancy terms that basically mean a stimulus which would normally produce pain, like a pinprick, now produces wildly accentuated pain in that process. So little pains become very big pains. And there's also allodynia, which is where things that shouldn't really producing pain, like rubbing on your skin, cold, things like this, now can become exquisitely painful. So exam tells you one set of things. We also look for functional testing. They can do things like bladder testing, or they can do imaging with an MRI, or they can look for abnormal neurophysiological tests like nerve conduction studies, electromyograms, galvanic skin response, these sorts of things. These all just say some injury to a nerve has occurred, and that increases the argument that it must be a neuropathic pain then. There are many different types that are out there, those due to compressing nerves, inflaming nerves, cutting nerves, central injuries like spinal cord or stroke. And the bottom line that's, these have differences to them and differences to their responses to pharmacotherapy. But the key thing is that most of them have a certain element of spontaneous nature to them. And they tend to be a series of peaks and valleys that can happen without real prediction. They just they can come and go and become profound. They may have an evocable component to them like the allodynia, but they don't have to. They can just be there. And as a consequence, these types of pains are our default diagnosis if we can't find anything else, because we can't always see where that nerve pathology may be. When it comes to treatment, we also have a whole list of options for treating. We can get to etiological therapies, like I talked about, getting to the root cause. We know exactly what's causing the pain, therefore we try to treat it. And if it's inflammation, you use anti-inflammation things like this. In our pain clinic, we do lots of injection types of therapies, normally of anti-inflammatories. You can use counter-stimulus therapies, so it's called like transcutaneous electrical nerve stimulation. There's certainly physical therapy, psychological therapy. The thing I tend to focus on, though, is medical therapy, because that's what people normally think of when it comes to the different types of pain. When you look at the pharmacology of nociceptive pain, it is the pharmacology of traditional analgesics. It's things that came from the willow and from the poppy, and in their multiple different forms. We have opioids, the different sorts of narcotics, and we have anti-inflammatories that are both of the steroidal form, which is the corticosteroids, as well as the non-steroidal anti-inflammatories, all of which are inhibitors of cyclooxygenase enzymes, which helps then reduce a different type of inflammation. Notably, with nociceptive pain, we do allow use of adjuvants that they do help make some of these other medicines work better, but we don't typically start with adjuvants. In comparison, neuropathic pain medications is all about all adjuvants. It's not that opioids don't necessarily work, it's just as a general case, they haven't worked very well long term. And as a consequence, we utilize medicines that have other mechanisms of action. This includes things like antidepressants, which can be things that are serotonin and norepinephrine reuptake inhibiting types of drugs. We can use different anticonvulsants to sort of tone down injured nerve cells. Antiarrhythmics will do the same kind of a thing. They're sodium channel blockers. Antispastics, that is, if someone's having a muscle spasms, you want to use something to treat that. And there's a whole pile of other things that have been demonstrated, alpha adrenergic agents, topicals like capsaicin, and so forth. Know that unlike nociceptive pain management, in which you can give enough morphine that people can walk on broken legs, not very efficiently, but they can walk from a pain standpoint. In comparison with neuropathic pain medicines, the realistic goals that we have with them are not pain abolition, but it is to make those peaks and valleys of the pain, the coming and going of it, make them just of lower amplitude and farther apart. So less episodes of less intense pain is a realistic goal with the use of these types of medicines. Other treatment modalities are these other things I mentioned. We don't forget about them. They are important also in the treatment. And when you're trying to get away from traditional analgesics in the form of opioids, things like this, we make sure that we invoke these other options, which include like TENS, psychology, physical therapy, injection therapies. Now, there are some pains that don't quite fit this nociceptive neuropathic pattern. They're now called neuroplastic types of pains, but what that means is still a little bit fuzzy, but they are functional pains that lack easy and visible pathophysiology, but they do seem associated with specific stimuli that are going on in the same way that nociceptive stimuli do. Visceral pains are very commonly within these functional pain states, which include things like irritable bowel, interstitial cystitis, non-cardiac chest pain. We're not quite sure what to do in this population. It's still the great unknowns related to appropriate therapies. Opioids may or may not have effectiveness. There could be other dysfunctions that are going on at the same time, and so you may need to use other medicines, but we tend to use a mixture of both nociceptive and neuropathic pain medicines, just trying to find which one works, this thing that we don't quite fit. Notably, all of these things get a little complicated in the sense of when you get to chronic pain, we talked about the pains appear out of proportion to their identified pathology. And a lot of that is because pains, both nociceptive and neuropathic, are modulated by other events that occur. These include things like anxiety, depression, and so forth. There's a really old clinical literature where they did nasty things to medical students where they would make them stressed and then distend their bowels or things like this, and could show that indeed there is a relation between sensitivity and stress. Likewise, there's plenty of measures of depression, anxiety, and there's links to panic disorder, other genetic linkages. So the bottom line is, when we're talking about these pain medicines that I'm talking about, we're also needing to work on the emotion side of things. And this is also where the adjuvants come into play, because Some of them are already doing that. We use antidepressants that also have anti-anxiety effects and analgesic effects. And gosh, they seem like the one that you should use if you're having a lot of depression, anxiety, and pain. So to summarize my half of this talk, there is clinical pain, and there's plenty of evidence that there's more than one type of pain out there. It occurs from many disorders that can have multiple etiologies that include things that are nociceptive, neuropathic, as well as these other neuroplastic components. We tend to treat them etiologically if we can, but otherwise we follow the general rules of what you do for nociceptive and what you do for neuropathic. And at present, all of these treatments have problems associated with them. And so as a researcher and such, we know there's a need for new medicines so that we can have an improved understanding of the mechanisms. So we really can do etiological therapies, not just generic trial and error. So I'll give up my screen here and turn it over to Jen, who's now going to talk about those etiologies that, at least as the level that we understand them. You're muted, I think.
Yep, there we go. Okay, can you see my screen? Yes?
Yes.
Perfect, thank you. Okay, so I'm going to talk about more of the anatomy and physiology of the biological systems that give rise to pain. So most of the information that we have and what I'm going to tell you about today is derived from injury-related studies that are focused on acute tissue injury. And many studies have compared responses in humans with responses in non-human animals. You know, mostly today people are using rodents for these types of studies. And if we have time at the end of these slides, I'll talk a little bit about what some of these pain measures are in rodents. So some terminology, when we talk about pain, that's uniquely human because it involves the report of emotions. So when we talk about pain-related sensations in animals, we talk about nociception, or refer to it as nociception. So animals are really models of nociception, which is more the transduction and transmission aspect. Some other pain terminology. So if you look at a stimulus response function, so stimulus intensity being on the x-axis here and pain intensity being on the y-axis, and you focus on this blue curve and consider that a normal response to pain, you can see that if you have a high intensity physical stimulus, it's in the noxious range, you can get a high subjective pain intensity rating. And similarly, if you have something that's not so painful in the innocuous range, you get a low level of pain intensity. But if you consider for a minute tissue injury, then you get a leftward shift in this normal stimulus response function, such that if you get a heightened pain intensity to something that would normally be painful, and this is referred to as hyperalgesia. So something hurts, and then an injury occurs, and that same stimulus hurts, but it hurts even more than it did originally. You can also get what's called allodynia, and this is when you develop pain in response to a stimulus that would normally not be considered painful. Similarly, you can shift this stimulus response function to the right with things like analgesic drugs, so that something that might normally be painful is no longer painful, particularly in the context of tissue injury, acute tissue injury. So pain can arise from any part of the body. It can be superficial, arising from the skin, for example, or it can arise from deeper tissues like muscle, bone, the vasculature, or any of the internal organs or the viscera. So most of what we know about pain pathways has been defined for that more superficial, cutaneous, or skin-related pain. And these pathways are largely hardwired, and sensations, particularly for skin pain, can be very easily and well localized, and they're typically associated with tissue damage. This is not true for all sorts of pains, as Dr. Ness was alluding to. But there's something that happens in the periphery, whether it's an internal or external stimulus that causes activation of these particular afferent nerve fibers that send signals into the central nervous system, first into the spinal cord, and then they're eventually relayed up to the brain. And so we'll kind of walk through each step of this. So just to kind of touch on the basic wiring, our peripheral sensory nerves are pseudo-unipolar neurons. So the cell bodies are located in dorsal root ganglia, which are these sort of clusters of tissue within the spinal column, but outside of the spinal cord itself. And then there are two axonal processes coming from these cell bodies. There's a long axonal process that extends into the periphery to the target tissues like the skin, the muscle, the bones, the organs. And then there's a shorter axonal process that extends into the dorsal part of the spinal cord, which is the sensory part of the spinal cord. And then from there, there's all sorts of integration and modulation that occurs before signals are eventually ascend to the brain through specific pathways to various brain regions, principally the thalamus, and then it's spread out to a variety of other brain regions in the cortex and the limbic areas that are involved in the sensation and perception of pain. So step one would be activation of nerves. And there are, as you can see in this picture, a variety of algogenic substances that can activate peripheral sensory nerves or primary afferent nerves. And it can be immune cells, it can be things that are released from sensory nerves themselves. So for example, damaged cells can release chemicals that may activate and sensitize these sensory nerves. There are things that the nerves release themselves that can cause vasodilation and plasma extravasation, which is also known as neurogenic inflammation or nerve-driven inflammation. And then these changes, or these chemicals and these activation of these nerves can have local and central effects. And so I've always found this interesting. I just learned about this a few years ago from Dr. Ness, but a lot of what we know about these excitatory or algogenic substances is derived from blister-based studies. And essentially, in these studies, there's a beetle called a blister beetle, and there's a chemical called cantharidin that's isolated from the beetle. And it would be put on these little pieces of paper and placed on the skin, and it would cause a blister to rise. And once the blister rises, the epidermis would be removed and expose the blister base, so that raw, irritated skin underneath the bubble of a blister. And then this blister base would be bathed in various solutions, so different chemicals, and then the subject, the poor subject that was undergoing this, would be asked to rate their pain intensity. They would move a pointer along a scale, and then the pointer would be connected to pulleys by a lever, and the movements would be recorded on a kymograph, which is this instrument that you see here on the left. And so people were able to obtain stimulus response functions, related to the application of different chemicals based on drug concentration and so forth. And so that's how we know what a lot of the algogenic substances that activate sensory nerves are today. But so there are these chemicals within our bodies that come from within that activate sensory nerves, but there are so many, as we all know, other stimuli that are painful as well. And it's these types of stimuli have originally been defined by human volunteers. So we know that things like heat, extreme heat and cold can be very painful. And in humans, this is typically above 42 degrees Celsius or below 4 degrees Celsius. We know that not all types of mechanical pressure or stimulation are painful, but some mechanical stimulation types can be. So there's low pressure or vibration that's typically not painful. But if you think about, missing a nail when you're hammering something into the wall and you whack your thumb with a hammer, that's high pressure, that's painful. Getting a shot or a pinprick, something like that, is also painful. So knowing what causes pain in a controlled fashion allows the study of it. And it's really doing these sorts of things in human volunteers that has defined a lot of what we know about what's considered painful. So let's talk about these primary afferent or peripheral sensory nerves that I keep mentioning. So there are a variety of types of fibers or axons that are associated with these different sensory neurons. And they're defined in part based on their myelination. So you can see in this figure on the bottom right, there's an axon in blue that's ensheathed in Schwann cells, which forms what we know as a myelin sheath. And some of these axons have no myelin sheath, like this C fiber here in red. And then there are other fibers called A fibers that have varying degrees of myelin wrapped around them. And so there's C fibers, A delta, A beta, and A alpha. And as you can see, the more myelin there is wrapping the actual axon, the diameter, so how wide the axon is, increases. And with increasing diameter, you get increased conduction velocity, or the speed at which these axons are transmitting information. So, and we know this in part from nerve conduction velocity tests that Dr. Ness showed an example of a little bit earlier. But what you see here on the right in blue is in red, well, so the blue figure, but the red traces are individual recordings of conduction velocities of individual afferent fibers located in a frog sciatic nerve. And then what you see here in purple is sort of some summary of activity of all of these fibers. And so when you provide a stimulus to this nerve in this example, you get a very, very rapid, large response that's very quick, that's carried by these heavily myelinated A alpha and A beta fibers. Then you get a slightly slower response that's carried by the less myelinated A delta fibers. And then finally, you get a very slow latency response that's carried by the unmyelinated C fibers. So the diameter of the axon is positively correlated with conduction velocity, or the speed at which it transmits information. So it's primarily these unmyelinated C fibers and the lightly myelinated A delta fibers that are considered nociceptors, which are the fiber types that transmit information related to painful stimuli. And A delta fibers and C fibers transmit different types of information, or different kinds of pain-related information. And if you think about whacking your elbow, there's that really sharp first pain, what's called first pain, that you feel. So you know you hit your elbow, you can know exactly where it hurts. And then there's sort of a slower onset pain that's more dull and aching and harder to localize, or more diffuse, that's called second pain. And based on a series of parallel studies, evoked potential studies, and psychophysical studies, we know that first pain is mediated by these lightly myelinated A delta fibers. Second pain is myelinated by the C fiber responses. And we know this because, as you can see in this figure, if you do something that selectively silences or stops these A delta fibers from transmitting information, you can do away with the sharp first pain and you're left with second pain. And then conversely, if you block the C fiber response, you're only left with this sharp, quicker first pain and no more second pain. So just to put this in context with other things in our daily lives, these slowly conducting C nerve fibers are somewhere in the range slower than walking. The A delta fibers that transmit the quicker first pain their conduction velocity speed falls somewhere between an Olympic sprinter and a very fast bicycle, or a greyhound dog, or a car on a highway. But certainly there are these very, very fast touch-related fibers that transmit information faster than a cheetah runs, but slower than an airplane. And this is always kind of a fun thing to talk about. So it's really quite remarkable how quickly some of this information can get to the central nervous system. So there's been many characterization of different types of nociceptors. So within this specific A delta and C fiber type of neurons, some of them transmit particular types of information. Some of them transmit a variety of types of information. And the ones that transmit multiple types of modalities, such as mechanical stimuli, heat, and cold, are called polymodal nociceptors. Both A fibers and C fibers can be polymodal in nature. There are some C fibers that may transmit only one type of information, such as mechanical information, or heat, or cold. Similarly, for A delta fibers, there are some mechanosensitive A fibers that don't respond to temperature. But these responses in general are changed by chemicals of inflammation. And this is particularly important to note that there's a population of sensory fibers called silent afferents. And these are called silent because they normally do not respond to mechanical stimulation. However, once they become, they're chemically sensitive, and once they are exposed to chemicals of inflammation that are generated within our body, for example, they become mechanosensitive, and they start responding to mechanical stimulation. And so a lot of what we know about these different types of nociceptors come from animal studies. And one type of these studies, you can see an example, this figure here on the right. This is an ex vivo study of cutaneous sensory neurons. So this is actually the hairy skin of a mouse hindpaw that you see stretched out here on the screen. It's been shaved, and it has an intact saphenous nerve, intact dorsal root ganglia. So that's what you see. I don't know if you can see my my cursor, but the clusters of cell bodies of the sensory neurons, and then the spinal cord that they innervate. And so what this allows for is to actually stimulate the peripheral tissues in a biologically relevant way, with non-noxious mechanical stimulation, noxious mechanical stimulation, different temperatures, different chemicals, and then you can record from the cell body of the neuron that's being stimulated that's located here in the dorsal root ganglia. And you can measure conduction velocity, and this really allows for a thorough characterization of different types of nociceptors and what they respond to. So after the peripheral sensory neurons are stimulated and they transduce and transmit information, where does that information go? Well, the very next step would be the spinal cord. So the information comes in from the periphery, and here's the dorsal root ganglion here that I mentioned where the cell bodies are located. The information goes through the dorsal roots into this dorsal part of the spinal cord. So if you took a cross section of what you see here on the left, this is what the spinal cord would look like. Sensory information goes into the dorsal or upper half of what you see here. And from there, there's a lot of integration and modulation that can occur that we'll talk about in just a moment. But inputs are organized in a pretty interesting fashion. So you probably all are familiar with dermatomes, and that's what you see here on the left is a dermatome map. And this is the sensations on the exterior part of the body that come from a single nerve root. And these were mapped using people who had undergone spinal cord injury or disease, and also herpes zoster. So typically when someone gets shingles, they get a distribution along a single dermatome of the lesions related to the virus. There is also what's called a sclerotome map. And this is sclerotogenous pain arises from deeper tissues like ligaments, tendons, joints, facet joints in the back, discs, etc. And a sclerotome is a deep somatic tract that's innervated by the same spinal nerve. And so often we'll have the experience of pain that is referred. So it may come from inside the body or from a deeper tissue and then show up or be sensed on an exterior part of the body. And that's often related to these sort of sclerotome mappings. Where are connections? Well, as I mentioned, the sensory connections are within the dorsal horns or the dorsal component of the spinal cord. And the different regions have been named either based on their location, as you see here on the left, and also based on their structure and function. And this is what we typically use in preclinical research. It's called Rexed's lamina. And so it's sort of divided into layers. And what you can see on the right is that these peripheral fibers will come in. They will, depending on the fiber type and the tissue type, and they'll come in and they'll sort of terminate or stop their projection in one of these lamina of the dorsal horn, where they can then interact or connect synapse with interneurons, projection neurons. So interneurons are local connections. Projection neurons then would send information through ascending tracts up to the brain. There are propriospinal connections that traverse several spinal segments and help integrate reflex behaviors and things like that. So it's actually quite complex. So this is an interesting example. How are we doing on time? We're doing okay. Showing the differences between, so Dr. Ness alluded to, you know, different sensations, different types of sensations. And sensations are very unique, whether they come from the cutaneous or tissues, such as the skin, or deeper tissues, like some of the other things I've mentioned, viscera, muscles, joints, and things like that. So just looking at how these inputs are organized in the spinal cord, this is a drawing of an actual single nerve fiber projection that comes from the skin. So it goes into a single spinal segment. It's sort of arranged in the superficial dorsal horn into these tight basket formations. You can see it has a limited laminar distribution. I mentioned Rexed's lamina, so the layers 1 and 2, you can see it's sort of concentrated right there. It has a limited number of contacts, and it's very well organized. This is in contrast to a single projection from a deep tissue nerve, and this one comes from a visceral organ. But this is, again, a single projection, but it looks quite different from what you see with the cutaneous projection. So it's very widely distributed. It traverses several spinal segments, which you can't see here. It's spread out over multiple Rexed's lamina, or layers of the dorsal horn. And this is part of what gives rise to the different types of sensations that come from easily well localized things on the external part of the body versus more difficultly localized sensations coming from within the body. So let's talk about synaptic transmission. So generally speaking, an action potential comes from, or these electrical signals come from the periphery. They arrive at the synapses in the spinal cord. These electrical signals cause changes in voltage-gated channels that allow calcium to enter, that essentially allows for neurotransmitters to be released into the synapse that can either depolarize or hyperpolarize the postsynaptic cell. So that's a very simple, straightforward way to think about it, but it's really quite complex. So we know that in general, the chemicals of interest related to pain transmission are, there are several of them in the spinal cord. Glutamate is the primary excitatory neurotransmitter. It's an excitatory amino acid. There are other peptides, such as substance P and calcitonin gene-related peptide, and others that are also present that act as excitatory neurotransmitters. So you have your primary afferent or peripheral sensory neuron here on the left. Your action potential that arises from a noxious stimulus is coming into this synaptic area, causing changes in voltage-gated channels, release of neurotransmitters, as I mentioned just a moment ago, into the synaptic space. These neurotransmitters can then act on their receptors on the postsynaptic cell and excite it. And in a projection neuron, you would have this cell sending activity to the brain. I mentioned sort of interneurons that are local within the spinal cord. These are within the dorsal horn. So there are excitatory and inhibitory versions of these that can dampen or facilitate transmission of pain-related signals. And then you also have descending signals that come from the brain down to the spinal cord and can influence synaptic activity, again, and by either facilitating pain-related signals or inhibiting or dampening them. Okay. There are various categories of what we call second-order neurons. These are the neurons within the spinal cord. Some of them respond only to to innocuous or non-painful information. Some of them respond only to painful information, and some of them are mixed, and they respond to a wide range of information. And what you see in this figure is from an older animal study in the rat, where they were recording from different types of neurons, second-order neurons within the spinal cord. And you can see the receptive field, or the area on the outside of the body that the neuron would respond to, drawn in black on the little diagram of the rat. And then you can see the stimuli that were applied. So BR is brush, this is non-painful, and PI is pinch. So that would be a noxious stimulus. And you can see in what's called a wide dynamic range neuron, or a mixed neuron that responds to a range of types of stimulation, that you get a response to brush, and you also get a response to pinch, and it's encoding. So that means that you get a set response to whatever this light touch is, and a more robust response to a more robust stimulus. And then in contrast, you can see down below a high threshold neuron that responds only to pain-related information. And that's exactly what you see in the graph. There's no response of this neuron to brush. However, you get a pretty robust response to pinch. These second order neurons can also be classified based on their subsequent connections. So I mentioned some of them remain in a given spinal segment. These are interneurons. Some of them project to an area that's several spinal segments away, as in the propriospinal neurons. And then there are those that project up to the brain. So those would be the primarily spinothalamic tract neurons that send information up to the thalamus, and then it's sent out to other areas of the brain for processing. So from the spinal cord, let's talk about these ascending pathways. There are a couple of ascending pathways. The spinothalamic tract is the primary pathway for pain-related information, but it's not the only pathway. And typically what happens, so the primary afferent axon will come in through the dorsal root entry zone and form what's called Lissauer's tract. And then it will bifurcate. It may ascend or descend several spinal segments, and then synapse on another neuron in its target lamina, or layer of the dorsal horn. Then the second order neurons will decussate. So the spinothalamic tract neurons cross over to the opposite side of the spinal cord and then ascend in two different sort of components. There's what's known as the neospinothalamic tract, which carries very quick information to a special part of the thalamus. And this is what's the pathway that's important for localizing where a stimulus is on the body. And then there's the older paleospinothalamic tract, which carries information that's probably more related to internal sensations. And it goes to, it's more diffuse in its projections through the brain. It carries a lot of limbic system information related to the unpleasantness of the sensation, how much we don't like it, and how averse we are to it. But regardless, the eventual target of these pain-related pathways is the cortex of the brain. And there are a variety of regions, or various regions you can see here on the left, where pain-related information is eventually relayed to, and these regions are part of processing information. And we know what these regions are because of injury. So for example, if someone has a stroke in a particular area of the brain, and it might impact just a certain component of their pain processing abilities. And of course, we also know from functional imaging studies. And so I'm quickly going to mention this figure on the right, which is from one of these functional imaging studies from 2004. It's quite an old study, but it's really interesting to me. And so in this study, people's brains were imaged while they were asked to give subjective ratings for a physically induced pain. I believe it was a thermal stimulus that was applied maybe to the arm, versus a hypnotically induced pain, versus when they were just asked to lay there and be still and imagine something painful. And what you can see in the picture is that while there's most brain activation to a physically induced pain, there's certainly brain activation in pain-related areas of the brain during hypnotically induced pain and also imagined pain. So for example, regions, as you can see toward the bottom. And the subjective pain ratings, when these individuals were asked to give a pain rating for each type of pain, their subjective pain ratings for the physically induced pain and the hypnotically induced pain were similar. So this is really quite interesting. Dr. Ness mentioned that part of the definition of what pain is does not necessarily have to involve tissue injury or inflammation. And this is a prime example of that. I don't know why it's not letting me use my buttons anymore. Once information's in the cortex, there's a somatotopic organization, or a homunculus, a little man in the brain, where different parts of the cortex are dedicated to sensations that come from different parts of the body. And areas like the lips and the fingertips have a much larger representation than areas like the elbow, for example. But in the end, it's all connected, and we have what's called the pain neuromatrix. And essentially, this is the idea that there's a specific pattern of activation of nerves and regions in the brain that sort of provides a signature for the experience of pain or the perception of pain. So it's a very complex system. And I mentioned there are also some descending modulation when I was talking about synaptic connections in the spinal cord. So things like stress, which is an external experience that's processed, can be sort of turned into modulation of incoming sensations from the periphery. So this happens because there are areas of the brain that send projections back down to the spinal cord, to the same areas that are receiving incoming sensory information, and then can either ramp up the incoming activity or sort of dampen it to influence how we experience pain. So things like stress typically across the board make pains worse. There are other things like exercise or perhaps part of the placebo effect that have to do with descending modulation that is inhibitory in nature. I'm not sure we really have time to go over pain-related behaviors in rodents, but we do a variety of things that may be reflexive in nature, organized at the spinal or supraspinal level. We do things that are not reflexive in nature, so spontaneous pain behaviors. Animals, rodents will actually exhibit facial expressions related to grimacing. Our own Dr. Sorge was part of sort of characterizing this in rodents. And these things, avoidance of evoked stimuli is another, and these things are more related to quality of life and functional measures of pain. So we use a variety of both reflexive and non-reflexive tests. There are lots of fun, innovative tools where we're able to use specific wavelengths of light to excite or inhibit the activity in sensory neurons, either in the periphery or in the brain. This is related to certain ion channels in the cell membrane of sensory neurons that open and close in response, or open in response to different wavelengths of light, allowing for excitation or inhibition of cells. There's a novel technology called chemogenetics, where there are designer receptors that are exclusively activated by designer drugs. So in a spatial, both of these techniques allow for spatial and temporal control of living cells or sort of intracellular signaling cascades that can give rise to pain. So there are lots of neat ways that we can study pain or nociception and things that modulate it in animal models. And so just to kind of finish up or summarize here, some but not all pain pathways are well defined. Pain pathways are defined based on sensations related to tissue injury. What we know is based on a combination of human and animal information. And this is probably something that Dr. Ness could comment on. He certainly has more experience with pain treatment than I do. I have none. But the issues with pain treatment typically aren't hyperalgesia or these sort of accentuated sensations to things that are normally painful. It's more the issues typically with chronic pain also typically relate to ongoing or spontaneous pain, to the experience of allodynia, so you experience pain from something that shouldn't be painful, and then also sort of the affective or limbic areas of the brain, what they process related to suffering, coping strategies, psychological comorbidities, and so forth. And I always like to sort of put out this philosophical question at the end, which is, why is there chronic pain? You know, this is really the problem in the pain treatment world. And it could be that injury produces irreversible changes in the nervous system for which there is no compensation. And that may be true, although I think, there are certainly instances which there are changes that happen, but that can be reversed. There's a lot of plasticity in these pathways. It could be that neurons have some sort of homeostatic task to perform, and because Dr. Ness and I study the bladder, for example, that's what comes to mind. So you have neurons in the bladder that are responsible for sensing when the bladder's full and when we need to go use the bathroom. And so they have a homeostatic task, but they're the same neurons that convey sensations of pain or discomfort. So it could be that, because these neurons have a homeostatic task, pain is an unavoidable side effect of their inability to sort of take a vacation or rest when there's something that's gone wrong. Or perhaps it's that we evolved too fast. And maybe chronic pain is just part of the disease of old age, because it's really a relatively new phenomenon. And it seems that the more our lifespan increases, the more things like chronic pains or chronic issues tend to be a problem. And so so this is from Dr. Ness's perspective, but when your doctor says, I don't know why, they might not just be a jerk. They're probably being honest with you. And there's a lot more to understand in order to treat pain more effectively. And in most cases, doctors who are trying to treat pain are just doing the best that they can. And I want to leave you with this lovely, simplistic diagram of pain hypersensitivity mechanisms. And this is just a reminder that it's all very, very complex. And there's a lot that goes into the sensation or experience of pain at every level. Yeah, it's a hard thing to treat. Do you have anything to add, Dr. Ness?
No, I think that says it all. I mean, they might be a jerk, by the way, but but yes, we all have, we just have to admit our ignorance is what's necessary, to be honest. So.
Do you guys have any questions? I don't know if there are any questions let me stop my screen share.
I don't see any in the chat.
Okay.
So I'll pose a question for the two of you. So given how much, so I'm always struck by how much we know about the system, all the different receptors and all these pathways. We know so much about the anatomy and how that functions. Why are we still using drugs from thousands of years ago as our primary treatments?
Well, I would say as an answer, I'm always surprised by how little we know about the whole process. We were using these main traditional analgesics from willow bark and poppies long before we had any idea of what they were doing. And why do we maintain using them? Because they work. The reason we found them in the first place was because they work. And knowledge didn't have anything to do with it. And so I think that's until we can come up with things that are better because of this knowledge. But to date, I mean, there are some things that are encouraging, and particularly for these kind of pains that we don't understand, we don't understand them because they're not responding to the normal things. So, I still see hope in these things. But I got started at this about 30 years ago. And at that point in time, most of that diagram that Jen had weren't known. I mean, weren't even postulated. So that we've learned an awful lot in a short period of time. We just haven't quite translated it.
Yeah, and I would add from a primary afferent standpoint in particular, we've discovered various targets, ion channels, maybe they're voltage gated in nature, maybe they're ligand gated in nature, that, in a particular setting in an animal model, a particular type of controlled injury or inflammation, and administering a drug or an antagonist that might shut down one particular protein or target on the sensory nerves, it might fix the pain or help the pain, improve pain outcomes in an animal model, which is very controlled. But there's stimulus modality, right? There's type of injury, as Dr. Ness alluded to, and there's just a whole lot of redundancy in the system. And I think, particularly for chronic pains, you start thinking about like polypharmaceutical approaches, because it's not just one thing. One thing becomes another, which becomes another. There are so many things that can impact the experience of pain. And this sort of gets at a question that I see in the chat box, which is, so it seems some people tolerate higher levels of pain. Is that a fantasy or is it real? Well, I mean, it's real. And there are so many things that can influence how, you know, a person responds to a painful stimulus. It could be something in their genetics. It could be something in their psychology. It could be, you know, a huge number of things. And I don't know, Dr. Ness, if you want to add to that as someone who has so much experience treating pain patients clinically.
Yeah, no, I mean, I would just reiterate the same statement. That is, I think a lot of it is just pain is not just a sensation, it's a response to a sensation. So there's incredible numbers of modulators that are in there, and you know, how people respond to things is very person dependent and dependent upon their, like you said, their genetics, their psychology, their life experiences, their environment. There's any number of things that modify, that could make people tolerate things better. And then there's things that can make them tolerate it worse, depression, anxiety, things like that. So it's just, humans are not very simple. And as a consequence, we can be pushed in lots of different directions. And with the same person who is exquisitely tolerant of pain at one time could become exquisitely intolerant of pain in a different setting. I can tell you my daughter, when she was little, if I tried to clip her nails, it was a screaming match because of how much pain it produced. But when she had to get an IV at the doctor's office to get an antibiotic, didn't flinch a bit. You know, it had to do with social context and other things. She was viewed as exquisitely tolerant, just not in my experience.
So
I have a question for the experts. Sorry, Robert.
no, go ahead.
So I'm really interested in this idea of distress tolerance, right? And just kind of as an anecdote, like I can think I've you know, in my younger days was an athlete for years, and sprains and strains and bruises don't bother me at all. And now as a parent, stepping on Legos, as painful as that is, I don't think about it much. I just continue with my day. I was playing tag with my kids the other day and fell and, you know, hurt my wrist. Actually, if I think about it, it's very sore right now, but I just don't really care. But if, you know, I experienced nausea, which I just really hate. I'm not sure if that's really in the pain realm, but I very rarely have nausea. But if I was nauseous, that might just put me down. I wouldn't want to do anything. I hate the way that feels. Really dislike it. Hate motion sickness too. And I'm curious, in an example like this, if there's you know, like a distress tolerance intervention where you can help people to get to the point where they'd say, let's say in my case, yeah, I'm nauseous right now, but who cares? I'm just going to move on. The same way I do with sort of bodily pain.
Well, I think that the answer is there certainly are therapies that are like that. Talk to Burl, who was on at least earlier, and things like this. That's part of the clinical psychology treatments, where they will use distraction therapies, reminiscence therapies, things that basically make it so the only thing you're focused on is your pain. That makes all the difference in the world, because distraction is a very powerful therapeutic in these sorts of things. So, you know, it's, again, we modulate things extremely well. You know, the classic, you know, what's interesting is stress, because this is something that Dr. DeBerry and I both study. Stress both pushes pain up, and there is a thing called stress-induced analgesia, which it can also push pain way down. That is, there are guys who are shot in battle and don't seem to notice the bullet wound until the battle's over, and then, wow, now it really hurts, type of things. You know, this kind of a process. That is, again, our body has these modulatory systems that are presumably set up to help us survive better, you know, just from as an organism. But we as humans have we have moved beyond sometimes our evolution of things that are beneficial. And it's like I liked Jennifer's final statement, which was, is this stuff that we're having more a problem because we live too long now, or we've evolved, we've moved beyond what our biological organism is supposed to be doing? Because it's supposed to let us live really well for 30 years. And then after that, I'm not sure, as someone who's lived twice that. So, you know, it's just modulation. And that's what we really need to understand, and how to activate the good modulations.
Yeah, and I'll also just comment really quickly, Peter, that because of the neuroanatomy of pain pathways, so you mentioned the difference between stepping on a Lego or hurting your wrist versus being nauseous, having your stomach hurt, and so the deeper pains, the visceral pains, are processed pretty differently. The information is transmitted more heavily to limbic areas, and across the board, people, human volunteers will rate visceral pains, even if the pain intensity is similar to something that's applied to their skin, for example. Pain unpleasantness is pretty much across the board always greater for things that are arising from the internal organs of the body. So your distress, your modulation techniques may need to be different or stronger, or I don't know. I'm just making that up, but processed very differently.
In the chat box, Lamaze, as in breathing in natural childbirth, is a perfect example where you can train yourself to activate the modulatory systems. So
yes, I think we have another question. Yes.
Elizabeth, did you have a question?
I don't know how to put this real well, but it just seems like today's people, in the words of my father, are softer than previous generations. The first, it's like, I get a headache and I don't immediately take something for it. I try to analyze it and see, okay, so like, what am I doing? And examine it. But it seems like in today's world, nobody wants to tolerate any form of pain. And they immediately go to take something for it, as opposed to really examining it and waiting it out. And, it might resolve itself. You may be uncomfortable, but I don't know. I see that not only in what y'all do, but everything. Nobody wants to be uncomfortable in any form or fashion. And I'm just wondering if that's we're becoming a bunch of wimps in a way, so that when there really truly is something to be, to say, yes, this hurts really badly, the effect isn't going to take effect as well because you've been medicating all along. So I don't know. I just see, I don't know. I just wanted to share that.
I mean, I would think that's a societal or cultural shift, moving away from being maybe as stoic as people used to be, or were raised to be, or thought they should be. But yeah, I don't know. Well,
I mean, I fall down and I scrape my leg. Okay, it hurts. But I don't have to immediately have pain medication to, I mean, that's sort of where I see people going to, those extremes, particularly with their children. Yep. It was kind of like a badge of honor to have scrapes and all that stuff when we were little kids. So.
And it speaks to the fact that our brain has huge modulatory systems. It's how we learn to activate them or utilize the ones. You can pull on those strengths inside you or ignore them. There certainly are profound cultural differences. Americans, as a general case, are wimpy when it comes to like postoperative pain, things like this. When you do the exact same surgeries in other countries, the reports of pain and the amount of pain medicines used are markedly lower. Americans are always top of the list.
Okay.
So, but again, it's partly because we've had the luxury of having those options available to us. We didn't have to learn the other alternatives. It's awfully easy to take a pill. And if you can afford it like you can in a rich country, it's amazing how often you take a pill. So, but it's about you got to train your systems, which is like most people don't do Lamaze if they don't take the Lamaze classes. It doesn't help. You need to learn the process of being able to do that in childbirth. then it's really effective.
Well, yeah, you can take all those classes you want to until you get there.
Yeah.
Trust me.
No, I know. My wife.
But I've done it.
It is an amazing. It's actually probably something worth looking at from the pain field again. It was looked at early on. It's never been sort of re-examined. That's a whole another set of things to look at. So. Well,
that's truly a visceral pain. And I've used that technique in other areas of my life. I didn't shed it then. I mean, it's come in really well.